I would like to introduce our panelists. First up is Dr. Jessica Fleischer-Black. She is the immediate past chair of this group, and she is full-time inpatient palliative medicine consult in Queens, New York at Northwell LIJ Forest Hills Hospital. Hi, Jessica. Next, I have Carter Newgarten. He is the inpatient medical director and physician co-lead of palliative emergency care at Stanford. Hi, Carter. Now I have Dr. Kirsten Engel. She is a full-time palliative care physician at Massachusetts General Hospital and is the medical director for Care Transitions Pathway. Hello. And finally, we have Dr. Caroline Meehan. She is also at Massachusetts General Hospital doing a combination of EM and palliative care, which is both embedded and inpatient. So thank you all for joining us today. I'm truly grateful for the opportunity to learn from each of you. And we'll begin with a few questions to spark discussion. I do hope that this is an interactive session. So if you have questions, please go ahead and put them in the chat and I'll do my best. And the panelists as well will do our best to follow along to what's happening in the chat. We'll respond there if we can or bring it to the discussion. So I am going to start with Carter, if that's all right. You've led the implementation of ED embedded palliative care at two different institutions. Can you share what those rollouts looked like and highlight any key differences between the two?
Sure. Yeah, I was privileged to be able to do this work both in Chicago and then here at Stanford also. And I think what I just learned through that is that like a playbook doesn't work because the needs of the institutions are so incredibly different. So the first time I did it, it was actually pretty easy. It was they're both academic sites, but it was a pretty quick rollout, and we already had some precedent of being in the ED, so we were able to just say, hey, we're going to have an extra person available there some days. I wasn't in a leadership position there, but we actually had the staffing so we could like go pretty quickly to a 5-day program where a lot of people rotated through, and then learned a lot about that I don't think someone necessarily needs to be ED trained to be able to work successfully as a palliative consultant in the ED, but you definitely need a person with the kind of right mindset and someone who's going to kind of go search and get work. Very different rollout here, where there's actually like an 18-month rollout plan with monthly meetings with all the different stakeholders, and a ton of work had to go in ahead of time just to get what we kind of thought had people all supportive. But then at the end, I think there was concerns, even that like we thought we were offering to help offload some of these like complex time-intensive tasks from ED faculty. In the end, there was concern that like, no, we actually want ED faculty and ED staff to be able to have all these conversations. So we don't want you doing too much of this. So almost had everything kind of like kind of pulled at the end. So I think just learning that you really need to figure out, one, be flexible, as I think Kirsten and I've talked a lot, and figure out what the institution really needs above this kind of just the departments, and figure out one where you can kind of help fill some of those holes, like what the institution is focusing on, whether it's decreasing patient mortality or length of stay, and figure out how you can kind of partner with some of those teams, but not also tie yourself to metrics, because those metrics can't change every couple of years. And if Vizient scores say something different, and all of a sudden all of your effort has been focused on this one thing, it's quickly to get get funding pulled or get support pulled as well. So and then being really thoughtful. A lot of programs have struggled. There's so many amazing embedded programs that have popped up, but then the key kind of the key champion has left or moved on, or staffing has changed and those programs have fallen apart. And that happened to me as well. So just being thoughtful on how to build a sustainable program, and you're really needing champions beyond you, I think is helpful.
Thank you. Caroline, you also have worked across two distinct hospital systems. What kind of insights or contrasts stand out from your experiences?
Yeah, so I trained at Brown for both my emergency medicine residency and then stayed on for a fellowship there. And during my fellowship, they were just starting their ED embedded program, which is a single physician embedded model. The physician is there 5 days a week, and I have the opportunity to rotate there with them as just a fellow at the time. And then here at MGH, we have more of a multidisciplinary team embedded in our ED. So either a physician or an NP plus a dedicated nurse navigator whose primary role is identifying the ED consults, in addition to having sort of basic goals of care conversations and supporting a lot of the work that's done in that environment. And then we also draw from a case manager as well as a social worker that's shared with our ostensibly hospice unit within the hospital. And so definitely pretty different feeling models. And I think one of the biggest things is, like, obviously every institution is going to have its own set of resources. And while those are both models that I have been in, have been clinician based, I think thinking about how to be creative and use resources within the context you have, whether your department has funding to hire an entirely embedded clinician, or potentially thinking about how we found a lot of success here at MGH with utilizing the role of the nurse navigators. And I can imagine some of those skill sets flexing to ED nurses. And certainly our ED nursing colleagues, since we've been embedded, have had a lot of interest in the work we're doing. And how do we sort of train up the resources we already have if you don't necessarily have as many resources to invest in an entirely new team, and in utilizing the folks that are already there doing a lot of this work and interested in doing it even better.
Thank you. Carter, do you mind if I ask some of the common challenges or sticky points that you saw between your two institutions in kind of getting this off the ground and also once it was up and running?
Yeah, I think there are unfortunately a lot of sticky points and kind of thorns to this type of work. The first one I alluded to a little bit is just like stakeholder buy-in and alignment, where there are so many stakeholders. At first, you think it would be the ED and your inpatient palliative team. And actually one site, like actually the inpatient palliative team can be a big barrier to this, because like what patients that's seen in the ED will I need to see? Is this going to generate more work? What about when there's not someone in the ED and then the inpatient team is called down? So are you staffed up? Are you able to support that? What is volume going to be like? That can be a big kind of, not necessarily thorn, but like a barrier to successful implementation. So I think, yeah, also trying to have not completely separate ED and palliative teams. Like this is one cohesive team that works together. Some people choose to work in both sites, but not forced to, can be helpful. But then beyond that, you have the stakeholder list just gets longer when you think, okay, then there are admitting teams, and you see someone in the ED and does the admitting team want you to keep following or not? That's not only medicine and ICU, but are there specialists? Is the onc team or heart failure team have opinions? So, and then you get into hospital leadership as well. So there's a lot of stakeholders, and trying to get them all in the same room, even the Zoom room, is hard. But getting people aligned by something. And I think if you go back to good patient care, and this is getting the right care to the right people at the right time, this is a huge population that is in need and of this extra support. I think you can generally get people there. The next thing is identifying what are the appropriate patients to see it in the ED. And that can be time intensive if you're just spending a lot of time screening charts. And we found ways to kind of automate it or flag if like a lot of people use the Epic end of life mortality index, so you can build that into a flag, but figuring out not only who may be eligible for palliative care, but who has unmet palliative care needs in the ED is tricky. I think AI has a really cool tool, and we've like developed something where here that really helps like not only identify patients with high risk mortality, but actually predicting when they have unmet palliative care needs as well. So there'll be some papers coming out about that. So I think like as much as you can implement those things for screening is great. And then I think also once you get the patients and then the data, it's also hard to, like, if you find the right people to get you the right data, finding what the appropriate control group is hard too. If you're not actually set this up as a randomized control trial, like even some of the papers said, like if you just choose patients to get palliative consult versus those who's not, like that's not a good control group. Even some of the control groups I've used in papers of like inpatient versus ED consults, different patient populations, not always a control group. So like making a compelling case about, like you can make the money say whatever you want of like I cut hospital length of stay and these things, but making a really good case for that outside of like a strict research design is tricky, because most of these programs you have to set up in kind of an operational way to just like get the thing off the ground and running. And then think about the last one is who's paying for it, and as I alluded to, staff leaves, staff turnover, you or the champion leaves, how these programs can be sustainable.
If it's okay, I wanted to ask you, you said that in your first place, there was a little bit of more precedence for being in the emergency department already, so it was less of a hump to get over to get started. What was the difference between what you were doing before there was a precedence for being down there? What did that look like compared to when you were fully embedded?
I think we luckily had another an APP at the institution before who was interested in going down there to kind of do rounds. So I think it wasn't as foreign to kind of both sides. So I think some of these programs can start informally, like if you don't have like you don't have to start as a gold standard fully like the gold standard would be the fully embedded interdisciplinary team, right? Very few places are able to kind of fully accomplish that. But having someone even with some interest in be like, hey, can I go down and round in the ED and check in, be like, hey, these are some of the patients that we typically see. Can we be helpful when you have that time, like starting and building slow to build some of those connections? Because once you're there and you have presence, generally ED clinicians, like we've surveyed them many times, people always love this. But there's always question at the beginning of like, when do I consult? Or if you're not here, who do I consult?
Mhm. All right, thank you. I wanted to ask this question kind of to the whole panel, just kind of as we shift from thinking about the big picture rollout strategy down to the nuts and bolts of the daily operations. Caroline, you kind of mentioned this, but how have you leveraged existing ED resources to support palliative care delivery? Kirsten, perhaps you would be willing to talk about that a little bit?
Yeah, so, and I'm just also looking at the question in the chat. Do we want to, as well, we can address that as well. So I was just starting to put a little something together for that.
Sure.
So I can just quickly, that person that just asked the question about whether, because it gets right to what a little bit what was being talked about ED border patients and whether we actually, that can have a challenge on productivity.
Right.
And we actually see them. We consider anybody in the ED, whether you're border or not, that we see them. So I think that's something that I just wanted to name. As far as the larger picture of what we do and the things that have helped us, I would highlight a couple of the things that Carter was already saying around the fact that identifying the patients is a huge area that we really, I think, needs to be addressed in any institution. And so that's something that we found that our nurses help with, but I think wherever you are and however you decide that what makes sense within your institution, thinking about how you know who you're going to see. And that's why it's relevant, this question that you're asking about productivity, right? That if you are seeing the borders or you're not seeing the borders. And that really, I think, speaks also to what Carter was saying about the fact that making it one cohesive team is really important, because you aren't just an ED team that's doing their thing and a inpatient team is doing another thing. An ED team can't function in the absence of an inpatient team. These really need to be teams that are working together, because you're never going to be able to do everything within the ED. And always people are going to end up going up and needing extent care beyond that. So thinking about yourself as an extension of your inpatient team, with that, of course, being the core for the vast majority of institutions that are doing that. So that's maybe a little side of that. And then do you want to, Maggie, I maybe not have answered all of your questions, so I apologize.
Okay, no, I was just asking about leveraging the existing ED resources to support delivery in the emergency department.
Yeah.
Because, to kind of moving from that big picture organizational planning, rolling out, how do I get buy-in? How do we actually make this work?
Yeah. So I think this varies a lot from institution to institution, but I think once people actually see what we do, as was already alluded to as well, that is definitely your biggest leverage. It also depends on what your institution really cares about. And Carter mentioned a little bit of that, Vizient, other things. Those things can really vary from institution. Obviously, being aware of what it is that your institution is really caring about at the moment. And like he mentioned, be a little careful because that can change. But I think there's sort of those two big buckets of things, right? What are we doing clinically for patients? And frankly, that touches immediately what the providers are experiencing. Because if we know one thing as ED providers that we all are, we are super excited for anybody to come and help us, right? And so if you can get your ED team, which some of us, Caroline's a part of our own ED team, is to recognize how this is actually impacting them. They are one of our most strident and strongest leveraging options, right? Because they love that we're there and they personally see the impact of what we're able to do. So our presence becomes a leverage in that we are working side by side with these people that care. That, of course, isn't everything, we know, because it also, we have to attend to the fact that there's a whole hospital around us and all the hospital priorities and so forth. But I would say for many hospitals right now, the border issue, which already has been raised, is an enormous one, and capacity is an enormous one. And we have the ability, so think about the leverage of the fact that we can sometimes get people out directly, right? So some of the patients that we're seeing, we're actually able to help them to leave on hospice. That is an enormous thing. Anybody that can get somebody out, and if you look at the studies that are out there, albeit I recognize what Carter was saying, it's not always easy to identify the controls. There definitely is evidence that we are having impact on the longer trajectory of these people's stay, and thereby decreasing length of stay and resource utilization and all of these things. So that's another leveraging element that you have that's going to hit the bigger picture of your hospital, by contrast to the sort of on the ground working with the ED providers that you're side by side next to, and them being really thrilled about the ways that we can help.
Right. Yeah, I wanted to give Jessica an opportunity to answer too. Both of you guys, Carter and Kirsten, have commented on the fact that this is one team. It's really important to not be divided between ED team and inpatient palliative team. And Jessica, you are the team. I know you're not the only person on your team, but you're doing both embedded and inpatient like on the same time, on the same day simultaneously. So what does that look like for you, and how are our borders impacting you?
Thanks. So for me, I'm part of a 3-person, 4-person inpatient palliative team. And basically, I do 1 day a week embedded in the ED, mostly because that's my interest and passion. It didn't really come from above. It came from me starting this job and saying, I want to do this. And if I kind of can't do it, I'll go crazy. So I do either a Monday or a Tuesday in the ED, and I kind of let my team choose. Based on how stressed out they seem upstairs, and then do that in the ED. And I make not much difference between borders or not borders. It's a smaller like community hospital. It's not one of these big academic centers. It's not got a big cancer center, but we do have a cancer office that sends some people. So like those patients will be like easy pickings. I'll definitely try and get to them early. Anybody who's got like metastatic cancer, I'll try and snag them up because I know that we ultimately will get consulted on them. And then, if anybody comes in extremis, I'll definitely go and kind of grab that. But I don't have a great system for how I'm picking people, honestly, because it's just me, and I don't even really have anybody to bounce the ideas off of. I sort them by age and kind of work my way down, and try and make sure that like the 102-year-old, we're clear what kind of like code status is and who the deciders are, and what's the issue. And then as I've been in the ED staff knows more. Like I've seen so much change just in the year of kind of ED staff telling me about somebody, giving me a heads up about something. And that can come from ED attendings. It can come from nurses. It can come even from like PCAs who will notice something. And then the other thing that I've noticed that I wonder about other people and what their experience is, like the ED attendings are just getting better at doing primary palliative care. Even the ones who claimed that they were like awful at it and terrible and they couldn't possibly, they'll call me and be like, okay, I did a really, it's not like you, but I did this code of care conversation, and we filled out a MOLST and I documented it, but can you take over now? And I feel like, yeah, like you did a great job. And then they'll be like, maybe I'll do a fellowship. Okay, never mind. So I want to know what other people, if they've had that kind of experience with their ED colleagues.
Do any of the other panelists want to respond to
I mean,
that?
I think we've seen an explosion with our mid-levels. So I'm going to see if Caroline agrees to that. I mean, obviously, when you're present, you impact everybody, right? So across the board, we have residents that have just indicate interest in attendings as well. But I think that the group we've seen, we have a very robust APP, so both NP and PA group, and we've seen a huge uptick in their just awareness and coming thoughtfully to us, interest in also beyond just within the clinical setting. We've had PAs in particular coming to us wanting to learn more, wanting to spend some of their non-clinical time learning more about palliative care, and wanting to help support their group in integrating some basic palliative care skills, primary palliative care skills into practice. So absolutely. I mean, I think we can never underestimate, we're humans, right? So like if you're present and you're around other humans that are doing things that are different than you, but you sort of pay attention, you're like, oh, that relevant for this time. So I think that's natural for any time we share a space. So that's super exciting and part of what we've really been happy to see.
Kirsten, I think just to add to that, circling back to the boarding issue, I think naturally, even if we weren't embedded in the ED, just how long our patients are waiting for a bed upstairs. I think palliative care conversations are evolving in ways that wouldn't have happened until day 2 or 3 of an admission. And unfortunately, the patient's still sitting down in the ED, and it's falling on the ED clinician to have that conversation. And then someone alluded to this earlier, but I think it's so rare as an emergency medicine provider, half of your day is spent on the phone fighting, trying to get a consultant to come down and see your patient. And then strolls the palliative care provider who's not only willing to see the patient, but self-identified the patient as having a palliative care need and is willing to talk to you about it. So we've really built some really lovely relationships between the palliative care and ED team. And it's great to see them being interested in doing some of this work themselves.
It's one of the things that was surprising to me when Carter said that there was a little bit of a hump to get past with EM buy-in, because yes, as ER doctors, we're like, thank you for coming and helping me. So were you going to say something, Carter?
Yeah, no, I was going to say the same thing too. Like it starts with, with any embedded program or any dedicated consult service or any whatever you want to call it, like primary palliative care education like has to be a part of it for those things to be successful. And I think you may start with the med students or the residents, and then you'll see the faculty start leading in and listening. And whether it's ketamine for pain if they're not doing it, or like some framework of like, oh, this you can actually just discharge someone from ED to hospice without actually like enrolling them in the ED before they leave if their symptoms are well controlled, like learning those things. And then ED doctors are like excited, like see one, do one, teach one, like it's like excited about the skill set and being able to do that or identify the appropriate patient. So I think, figuring out how education is a part of the initiative, whether it's just that presence and talking or more formalized like instruction through the residents that then kind of filters up to faculty, depending on what kind of site you're at, is really key.
I think the boarding question is really relevant to also some of the other things that we wanted to talk about, specifically like the differences between doing palliative care consults in the emergency room versus the inpatient side, and how boarding and disposition planning can impact that. And I think it's also relevant. I know Jay, you said, Kirsten spoke to this already, but Jay in the comments asked, he's a medical director for home-based palliative care, so wondering if there was a role to augment a home discharge or avoid admission. So I wonder if you guys could expand a little bit more about those differences in how you're doing inpatient palliative care versus ED consults and that disposition planning. Caroline, do you want to take that?
Sure, yeah, I think there's obviously a ton of overlap between inpatient consults and ED consults, but the flavor of them I think can be quite different. And so I think timeliness is a much bigger factor in ED consults, ensuring that our teams are really, especially folks who may or may not have background in emergency medicine. There are so many metrics that ER folks are getting on door to doc to disposition. And so being as timely as possible with the consult you're getting in that space is of the essence. And so really trying to prioritize seeing them as soon as the consult rolls in, if you've deemed it's appropriate. Also having appropriate turnaround with the consult and making sure that your recommendations are dispo focused. I think that's such a fundamental process within the ED, is that's what ED docs are constantly thinking of. Where is this patient going to go? Are they going home with hospice, inpatient? And so making sure that you have both your standard palliative care consultant recs, but also how those recommendations impact and affect dispo. And I think that's one of the best ways also to show impact to the ED team. I think also being flexible. So often patients go for tests and procedures on the floor, but things are just so rapidly changing in the ED. It's not uncommon that I think we're mid-conversation in a hallway bed about goals of care and the x-ray tech rolls up. And so being able to sort of pause in some of these intense conversations and seamlessly roll back into it, I think it requires a lot more flexibility than if that happened on the inpatient side. There's no urgency. You can wait, maybe circle back about that topic in a couple of days. Also, I think a lot of times inpatient teams expect a really full, comprehensive consult, even if that's something that evolves over time. Whereas in the ED, I think giving yourself permission to, this is a really unique, anytime someone comes to the emergency department, it's because something wasn't going well or there was some sort of acute trauma, injury, or decline that brought them there. So I think it's a unique moment for people to be really vulnerable and open to having some of these more serious illness conversations. And even if it's simply in a 95-year-old clarifying their code status, if that's all you're able to accomplish in the consult, I think that is a win, whereas we wouldn't necessarily think of that on the inpatient side or even have a threshold to go see a patient for just a code status conversation.
Jessica, I wonder if you can talk about this a little bit too, given you're doing both inpatient and ED embedded palliative care, and sometimes, simultaneously on the same day. So how do you, one, I guess I'm interested in one, how do you triage, and two, how do you almost switch the frame of mind from inpatient to ED and back and forth?
Yeah, I can't say that I'm actually in my institution, and maybe this has to do with like being a community hospital. I'm not feeling like a huge difference in the in the type of consult. Like they don't feel like two different consults. They feel pretty similar. It's just a little bit of a question of with the ED consult, if it's initiating in the ED, I don't necessarily like know where this person is going, or I don't know like kind of the end of the story. I see that I see they've got issues. I see they're getting admitted. I know I should get involved, and then I do as much of kind of the full consult as I can, and then pick it up the next day if they get admitted. I'm curious, one of my colleagues, whose name is Nina Ricci, she does embedded pal care at a sister hospital at like the main, whatever, like the mothership, more academic hospital. And she is IM trained, so not initially ED. So I'm curious, Nina, if you don't mind me calling you out. Hey, hi. If you feel like there's really a big difference in what you're doing, ED versus inpatient.
Yeah, well, thank you for inviting me to this. And it's lovely hearing everybody because sometimes, so just for background, yes, I am fully embedded in the ED 5 days a week, Monday to Friday, during general business hours. And yeah, my prior years, I've been fully inpatient. So this was a very big shift to me. And I think it all goes back to what everybody's kind of saying, where it's really focusing on what is your role, what is the priority of your institution. So for here, for example, there is a huge push to try to avoid readmissions. There's a huge push to try to get patients onto hospice and not even admit them. So sometimes I have to shift my brain because when you're in the ED, that's the first thing I'm thinking is, does this patient need to be admitted, or is there a better hospice path? Whereas if I'm following them upstairs, obviously it's kind of more ongoing discussions and a little bit more in-depth conversation. So it is just different in understanding what your role is between downstairs and upstairs. At least that's how it feels for me.
I imagine that getting buy-in from stakeholders, no matter where you work, is going to involve decreased utilization, reducing admissions, length of stay, readmissions, etc. I am wondering what sort of resources you guys have found are required to help make those dispositions. Carter, you kind of commented about this, about people don't have to get admitted to get onto hospice. And there's a lot of education to the ED providers that are required to be able to make that happen. What, besides educating them, what kind of resources, like logistics, do you actually need for that?
I mean, I can definitely speak to that because just going to what Nina was saying, this is a big priority for our institution too. And so we do, like Caroline was referring to, think immediately disposition. And that's been something we've had to those people that aren't EM trained that are down there. We really have to get them to start their brains to start thinking disposition. You're thinking it at the same time that you are meeting the patient. But I would say case management, case management, case management in answer to your question. I mean, in the last 2 years since we've really been full force with this, I have learned so much about what case management does, the skill sets they have, the resources they have at their disposal, the connections they have, and we have 2 case managers that work with our team, and their ability to make things happen in terms of patients getting out of the ED or even out of the hospital as well once they're in, but out of the ED with our focus here is unbelievable. I think somebody asked me, what do you recommend about trying to get somebody from the ED to home hospice? Before we had a case manager, I tried to do this once because this patient's grandson was having his first birthday and he wanted to be home for this first birthday and he wanted to go straight from the ED on hospice. And it took me all day. I watch our case managers make this happen in a matter of minutes to hours. And a lot of that has to do just with the way they're so adept with the system. They have connections. They ask the right questions right away. They know what the barriers are going to be before you even start. So having a case manager as part of your team, if you're able, even if it's not directly part of your embedded team, learning to work with those people that sit down in your emergency department anyway, getting to know them and going up and working directly with them, I can't emphasize enough how important that is.
And Carter, I wonder, you had said if symptoms are well controlled, they can go home before they're enrolled in hospice. Is that what you were getting at?
Yeah,
Can you talk a little bit more about
Yeah.
that?
So, I mean, I think there's different paths depending on your institution and what the needs are. If you have someone who you're able to clarify goals, or they come in and goals are already clarified, you can, engage the case manager in the ED to help place that referral and find a company that can meet them at home. Their symptoms are well controlled. Like, they don't have to wait for the hospice team to come into the ED, meet with her, enroll them, send them home. If you're like, oh, maybe they just need a little bit of morphine or some pain meds or something, but like they're going to be okay for that day or 2 or whenever it is that'll take that hospice team to meet them at home, then you or the palliative team can give recs to the ED team to discharge them over a couple days or a few days of meds just to get them covered. I think it's always just clarifying, our goal is consistent with hospice, and do they want to get home? And then you can probably make that happen. If symptoms are really bad, then I would either keep them in the ED or do a short obs admission or supportive care unit if you're at MGP, and get them a little more comfortable before they send them out, or like consider GIP if the time is really short and they're going to be, and they want to be end of life in the hospital. So, sometimes I think more often than not, we actually end up just discharging and have the hospice rep meet them at home. But partnering not on the case management, well, what is in Chicago? We've spent a lot of time, and one of the hospice agencies had someone at the hospital already. So how quickly could they promise when they had it to come see a patient in the ED, enroll them, and get that commitment from the hospice team, or that rep to come during business hours on that day. So I think you do need the kind of right confluence of factors, the right patient where the goals are clear, not horribly symptomatic on a weekday during business hours or something. You need some of those factors, but patients who are overnight, who really want to go home and aren't symptomatic, they can absolutely place that referral and continue the process at home. A lot of hospice referrals are done just outpatient anyway from clinic, and it takes some days to get those things together. But typically hospitals are very interested in that metric, avoiding those admissions, avoiding those unnecessary admissions, not having patients die in hospital, that type of thing.
Carter, I think just to add one quick thing to that, if that's okay, Maggie, that I think even if you don't have a dedicated palliative unit or an OBS unit, but for those in-between patients who don't have perfectly controlled symptoms, but are on the stable side, need either a hospital bed to be delivered or just some basic tuning up before they're able to go home with hospice services. I do think for most EDs have an observation unit, and I think that's something that we can all be more creative about, how we're using our ED OBS units and potentially avoiding an admission in that way if it's really just a short stay that someone needs before they're able to go home with hospice.
Yeah, so creating like comfort care pathways for those OBS units, I think in particular can be really helpful. And like you can extubate someone in these OBS in like the ED OBS units if that's what goals we're asking for.
Right. Yeah, I wanted to point out that a lot of people enroll in hospice from home. And I think as ER doctors, I don't know if you guys felt the same way, but when I was practicing emergency medicine, I found it hard to trust that whatever I wanted to happen once they left my care, that it would happen. And I wonder if that's a similar barrier to other ER doctors to say, like, I'm going to discharge them while they're not enrolled in hospice with these meds for 3 days and hope that that all falls into place. Um, anything that you wanted to say about that, Carter? It looked like you were going to answer.
No, I think it's a good, yeah, no, it's a great point, but I think in the same way of like if I wanted to discharge someone with like ortho or plastics follow-up in a timely manner, like it's not always going to happen. I actually find like hospice can get there quicker than a lot of other specialists generally. So yeah, and like it's not always perfect. Sometimes they'll come back, something will fall through. Often it's like they get home and they realize like, oh, this actually isn't what I want, and they come back rather than like I find like a falling through the cracks of the hospice agency not showing up when they said they would. But yeah, I think also having a person to like hold their hand through that, like that'll be okay. We've clarified the important things. I still obviously like the ED team always needs to feel comfortable with the disposition plan, and I wouldn't like override it if ED team felt differently. But generally, like people want to like everyone's aligned. They want what the patient wants and get them home if they can.
Perfect. And I wanted to specifically, I don't know if you guys have seen this in the chat, but Alexandra Donnelly said, what advice would you give regarding discussions with local hospice agencies to get their buy-in for realistic start of care and turnaround time? Do any of you guys have personal experience with that part of this process?
Yeah, I mean, our institution has a close relationship with a couple of hospice agencies, one in particular. I think a lot of this is the case managers are the ones that really, really foster these relationships. So remember that. And I don't know if that's true in all hospitals, but in our system, the case managers have a specific communication route. They have something called Fornex, and I don't know if that's something in all hospitals, but that they're actually communicating directly with these hospice agencies. And that's happening weekends too. So it's not just a weekday, 9 to 5 kind of thing. It's also on weekends, and our hospice agencies are actually in our hospital, or liaisons are in our hospital until 6 p.m. and later on weekends, till 8 p.m. on weekends. So I think the one thing I would just highlight that I didn't realize until I came into the role that I was in, and we now have monthly meetings with hospice agencies, their revenue for their agencies, and granted, we hope we're working mostly with nonprofits, which we are, right? But these nonprofits, in order to do what they want to do, which includes doing a lot of free care, like they need to have a certain number of their people on home care. Because that's the way their systems are set up. And actually, they're happy to take people to hospice houses and happy to have people on GIP, but they're really motivated to have a lot of people on home care because that's actually what enables them to then be able to just run their whole system. It's a lot of what hospice nurses and hospice providers love is caring for people in their homes. That's why a lot of people went into hospice care, because they love going to people's homes. So while we have seen a relative explosion of people getting GIP care and going to hospice houses as there's greater attention to these things in hospitals, the hospice agencies are super committed to their core, which is their home care. And if you are trying to facilitate them getting somebody home, they are going to bend over backwards is my experience. I've seen them have a 9 and 10 p.m. visit at a patient's home after we discharge them from the ED, like a 9 or 10 p.m. visit. I mean, that's like remarkable, right? That they would actually enroll them the same day. So like Carter's saying, they aren't enrolled until they actually get home, but they're going to enroll them that same day. So I think it's, to the extent that you can work with your case managers, they're working with the hospice agencies, and frankly, just get to know a couple of the people that are involved with the major hospice agencies you're working with, because they're actually just sitting around and speaking with them and hearing what drives their agencies is really important in terms of understanding what they're going to be, how engaged they're going to be in working with you.
Yeah, does anyone else on the panel want to speak about their experience with kind of getting that collaboration with hospice agencies? Okay. Let me think.
I'll just say that, I'm glad that that things are so exciting, like that things are going well in Boston, but I'll say that here in New York, it's a little bit more that hospice agencies are theoretically very eager for your patients. And then when you ask them to please have start of care like tomorrow morning, they can't do that, or that's too much. Or certain things, with various different hospice agencies will be achievable deliveries of things, but there's others that it's never, it's sometimes not as quick as we hope.
Okay. Oh, okay. Sorry, I thought you were going to say something better.
No, I was just saying, yeah, a lot of regional variation. I don't know either. Yeah, getting like case management by getting your own connection. I think I had more success in Chicago of like an agency I could call that was there. I'm like, all right, can you come and talk to this patient right now? Or like, can you promise you'll get there tomorrow? I haven't developed as good of those relationships out here yet. I think that's like I think as you think about like this is one of like whenever you have this program like in any embedded or any ED palliative collaboration, like there's the getting it running and off the ground, and then and then there's these so many other pieces of like, well, what about hospice? What about the patients who are going home but they can't see your palliative care team because they're out of network or their specialist is elsewhere? Like, how do we get a palliative care resources for those other ones? Like, there's an infinite number of these other like crescendoing projects, and I think really deciding like, all right, what ones do we want to prioritize and focus on? Because you can't do it all with everyone unless you have this amazing team and resources and yeah, like focusing on the easily deliverables and what the institution needs and what you do to like get a program going and running, I think is important. And then yeah, give time. There's always more work to do later.
I see this question in the chat, and this is along the lines of something I was going to ask, but Allison is asking about the hours of day that the palliative teams I think are embedded in the ED, and said I find it more helpful to be there when inpatient IDT is there, particularly the social worker, but those are not the hours when the ED is most busy. And I also wanted to sort of ask it. I mean, you're all highlighting the importance of case management, and I'm wondering about what other kind of IDT team members are really important in this process in the emergency department. I see some of you guys responding in the chat. Clinician is there 9 to 5 at MGH, and RN is there to 7 to 5.
Hours are key, but we know that like peak hours are going to be later in the day, and that's when the most need happens. But that hospice discharge is harder at 9 p.m. And a lot of us palliative folks, if you have families or other things you're used to working the 9 to 6 or whatever, it's hard to convince people to stay late. So I think it's always just a little bit of a balance of when is the need in the ED highest versus when can people work the shifts, and yeah, when do you have the palliative social worker or whoever else inpatient that you can pull down for help. And then also the problem of shifting too late is then there's a lot of those overnight patients who are waiting, then they have to wait until you start your day at noon or something too. So I think there's balance and compromise for all of them.
I think obviously the morning hours are so much slower in terms of seeing that ED patient who is still mid workup and is really like a prime example to get ED palliative care involved. We're not seeing a lot of those roll in until at least afternoon. And so the way we've sort of anecdotally structured our services, because we have such a large ED boarding population, we often use those first few hours in the morning to see some of the ostensibly inpatient level of consults that have been placed on our ED boarders, so that we are filling the day still with consults, even if they're not that sort of acute new ED patient.
Carter, you mentioned that palliative care docs kind of get used to the regular business hours. And I think this, I guess it speaks to another question of mine is, as an emergency med doc, we are working all these crazy hours, and our expectations are that the consultants that we're asking for help from, they, if you're on call, like, I'm gonna call you and you gotta help even though it's nighttime and you're supposed to be sleeping. So I think that also kind of speaks to just fostering a good collaborative relationship between the two teams and the expectations. I'm wondering if you guys have any advice about that, managing the ED's expectations of the palliative care team, and where you're being flexible and where you're kind of holding that as a palliative care consultant.
Yeah, I think it's a good question. I could take a stab. I think not overpromising is important, and what is a reasonable amount of time for turnover, because I can't promise I'm going to be there in 30 minutes if I've got 3 consults. Or if you get pulled inpatient for something urgent too. So I think just being clear on like what constraints you have, and then what happens. It's also really hard, I think, to tell ED clinicians if I'm just there Mondays and Tuesdays, like have this threshold to consult on this day, but a different threshold when someone isn't there, and like trying to be like, yeah, like what remembering what days someone in there or not is tricky, and what those different expectations will be. So again, that's why like when you do have the inpatient palliative team on those other days, how they're going to be less responsive, but how responsive. And then the final thing, yeah, like the overnight question, I agree. I think having generally, I think generally palliative people aren't covering overnight consult, or like aren't coming in overnight. So yes, if there's an urgent question or something by phone. I still haven't gotten a lot of overnight consults. It's generally like an accidental page where like someone puts in a consult intended for the next morning, and then someone still pages it out or something. But yeah, so I think like having phone available by night is something nice to offer, but only if whoever covering that inpatient pager is really okay with that. So I think just saying like yes, and a lot of people are fine giving phone recs if there's like, oh, this is a question about this med or something, versus without actually seeing the patient at off hours.
Does anyone have any other strategies that they have found to be effective in just fostering that collaboration between those two teams, the ED and the palliative care team, I mean?
And do you want to speak to that? Or you're feeling like, I'm just thinking in terms of like what Carter was saying, setting expectations for.
Yeah, first of all, like I'm comparing the two institutions. I was at Brown. The way placing a palliative care consult worked was a phone call triage system where a voicemail was left, and so there wasn't necessarily direct feedback in real time unless an ED provider was physically there and could go talk to them. So I think just setting that initial expectation, so getting back to them quickly and giving them a lay of the land of like, hey, I have 3 consults. This is where this one falls in terms of my priority. I'll get back to you in XYZ timeline, so that they can factor that into where the patient is getting admitted and how they anticipate your consultation is going to factor in their decision making. But in general, honestly, I find, I may be incredibly biased, but I just think for the most part, the ED team is just so open and eager, and like even trying to like seek out. I would have issues sometimes with how long it takes our team to get back to them. And I'm like, do you guys have any feedback? How was that turnaround? And they're like, oh, we're not good. They're just a really appreciative, collaborative group, and have been like extraordinarily eager to collaborate with us. So I wish I had suggestions for how to build that. And I think we've just been really lucky that the ED team has really embraced having our presence there for the most part. I think the only cases I will say, I do think there is some hesitancy, I think especially earlier on when we were full-time embedded with folks who are less familiar and friendly toward palliative care. I think there were initially some hesitancy, especially when palliative was self-consulting on patients, of equating palliative with hospice, or thinking that it was too soon or inappropriate to start some of these conversations in the ED. And I think that's where education went a long way. And then certainly after time and having had experience with palliative care consults, I think everyone has really warmed to us. But those were the initial holdouts, I think have converted, and it just took a little bit slower education and explaining why we've identified this consult and what we think it could add, and that we're not here to like nail out the hospice hammer.
Yeah, it sounds like the collaboration has gone very well. Just allowing the ED to see you and see your value, and you kind of have proven your value over time to build those relationships. I'm going to ask this question from the chat from Thomas Fagan that says, in places you are hoping to start an ED embedded palliative program, what are the best ways that you have found to prove the need to the stakeholders? Anyone want to take a shot at that?
Well, I was writing a little thing now that I'll hit send, but one thing that I've tried was kind of doing a needs assessment kind of thing where I just like look at the board and kind of take a snapshot of it, over a period of time and say, like, these are the people I would have targeted if I were there. And then maybe even follow the course of those people and say, look, this person ended up with like a 3-week visit, and maybe we could have cut that off, or here are the things that I would have done. I want to just acknowledge, though, realistically, I think a lot of times the more robust programs, it comes from above. It comes from somebody with a big title who decides that this is a good idea. They heard about it somewhere. Maybe they'll watch this on YouTube and think it's a great idea. And then they make it happen. I think that that's what happened at North Shore. I think that that's what happened. Am I right, Carter, at Stanford?
No, I
No,
think I didn't have anything
okay.
about yeah, but I can talk about Stanford, yeah. I think it all depends on who you're talking to, and like you have the right people at the right time and you have staffing. So when I was talking to C-suite, I showed them David Wang's paper on this and be like, look how it shortens hospital length of stay and look at the money you save. When I'm talking to the palliative care stakeholders, I talk about like these are actually our patients. Like these are our clinic patients. These are patients that we're gonna see, but we can see them earlier and like not have the primary team mess up the meds for a few days before, but they're admitted. Like we can actually like we're just see them earlier and like lessen work. When talking to the ED, it's like we can offload these tasks that are really time intensive and help reduce boarding and things too. So I think like the pitch you're making is all dependent on which stakeholder you're talking to. And the problem is those needs are so different. So I think, and then the right people like, yes, do I want to, does palliative leadership want to dedicate their staff to it? Or if the ED is paying for it, are they going to dedicate some of their shifts to? It's like who's paying for it also and what their pro is going to be. I think the last thing what we helped to do was we like looked at all the patients who came to the ED who died within 6 months, and we showed like there's actually like 18 patients that did a day who were dying within 6 months. Like I can't tell necessarily if they were dying that was going to be an unmet palliative care need, but like that was a population that people were interested in. Like, could we have an impact here? Not stopping them from dying, but obviously stopping where they died. I guess that was how I took that, but it's messy and it's so different based off of who you're talking to. I feel like Vicky was really good at like reading the tea
Yeah, I
leaves
was just
and
gonna
things.
say,
So yeah.
I have to say Jessica's also like they're all true, right? Everything that's being said is true. And you have a really powerful, very vocal, high level leader is going to get this on the table so people are looking at it. But I mean, obviously what Carter's saying, I completely agree with that. I also agree with if you have with Jessica that there's a strong advocate high up, it's going to get just enough people to look at it so that hopefully you get there. But don't underestimate the value of we are all emergency clinicians, right? And so don't underestimate the value of the person standing right next to you and that's in the job you may do some of the time or used to do, and how you can impact them, and then how you can work together to figure out, depending on what your higher level people want, you can probably convince them of just about anything that you're going to be able to change. So quality of care, length of stay, hospital returns, all these kinds of things. There's all kinds of things, capacity in the hospital, all these things that depending on how you play it, you can play it the right way. And working together with the ED, I think a lot of times can be helpful just because you're right there next to them.
Jay asked in the chat, has anyone on the panel engaged a payer? And how did that go? Jay, can you clarify what you mean when you say a payer?
Sure. Thanks for taking my question. Yeah, so like an insurance or that type of thing.
You mean have we billed?
Yeah, so to reach out to the payer and say if we service your, I think back to what Carter was just saying, the pitch to the C-suite is we reduce cost and throughput and so on. Say the same thing to a payer. Well, we reduce costs for your members by utilization reduction, conversion to hospice, getting them off your books. I'm just curious if anyone has experience with that.
I personally haven't directly. I see something. I think it's an interesting idea, and I'm curious. What would be then the ask of saying like what would the payer's impact have? I'm just curious, Jay, to talk about on how they would support palliative implementation or in the AD. So it's a curious idea, but kind of like what would be the next step of that?
Yeah, they give you an embedded caseworker,
Cool.
give
Yeah.
you staff,
Yeah.
whatever you need as far as bandwidth to be able to do this work. And I think in the sense of what I hear a lot of folks saying is having staffing to do this. And so pitch it to the payer, say, we'll reduce your cost if you invest in our staffing.
It's an interesting concept.
It is, yeah. I think David Wang, who did the Scripps paper and stuff, I think he's CMO at a payer site, so he's the first person we should ask that question and see what we could get from it.
Good advice. Good
Yeah.
advice.
Thanks, Chad.
We are coming down to the last few minutes, so I'm wondering from the panelists, what should we have talked about? What should I have asked that I didn't ask?
I think everything was covered. I guess like just if any of the panelists have like kind of last tips of people like trying to get these programs or trying to do this, I'm off the
Yeah,
cuff.
what
I
are
would
some
just
takeaways?
Yeah, I
yes.
mean, and I think I'd say just remember your back, because most of us, I think, are all in emergency medicine, right? And we also have these conversations, people primarily in palliative care. Remember who you are as as an emergency provider, and help your palliative care colleagues, if they're not also dual trained, to just understand a little bit about what it's like to work in an emergency department. I think that's something that I hadn't. And I'll just give one specific example, but one of the things that we've worked a lot in trying to help our palliative care providers is just how important it is to pivot. So in other words, Caroline mentioned this earlier, but without that specific word, in the ED, we're so used to, we have one person come in and they're sick and we need to see them, but we have somebody else come in and they're even sicker and we need to stop or put that to a side for a moment, make sure they're got a tentative plan or initial plan, and we pivot quickly and we think nothing of it. That isn't how most palliative care providers think. They don't think about pivoting to go see the most acute person. And that is something that I think is just a core EM principle. It's also that disposition comes at the moment of meeting somebody. There are a lot of core EM elements that we have because of the job we've worked at, and that can be really, really helpful with helping to develop the skills of the palliative care providers that you're working with, and can really make you an enormous asset because you have that dual. For those of you that do, or even if you're just interested in, but you have that strong EM background.
That's incredible points, Kirsten. I think to add on, I think, yeah, there's the tips of like patience and flexibility. Like just roll with the punches. It's going to be different every day. It's different. There'll be unexpected hurdles that you hit. And then, which I think as emergency physicians, we're all really good at already. But then also, like don't recreate the wheel. There's a lot of people, like we've seen so many chats, and it's awesome to hear from Allison who's doing this, and like I'm just looking through the chat, like a lot of people are already doing this work. So don't recreate the wheel. Reach out. I think that's what I think that's one thing that we haven't always been great at, which I'm so glad, Maggie, that you're getting these people together to like have these discussions, is like learning from other people like on who've done this work, so we don't all have to like feel like we're in our silo. Because otherwise I think you are like hitting your head against the wall. Like, why did I like do all of this and create this work for myself and it wasn't fulfilling? But if you're not able to connect with other people who are doing it, like CAPSI has a good like toolkit to start off too. But I think that honestly, I think we as a EM HPM field, there's so many more people going into it. Like this is an aside, we send way more EM residents to palliative than we do IM residents. Like tenfold more EM people go into palliative than IM. So like there's so many more people, but like now we need to get back together so we can like really create these resources and write about it and share it. So it doesn't have to be recreating the wheel each time.
Totally, Carter. It's the fastest growing group of folks pursuing hospice and palliative medicine. Advanced training is coming from emergency medicine. And I think there's some very real, both environmental and characteristics of the group of emergency medicine providers, why these trends are happening. And I feel like just on a personal note, it's been really wonderful over my the first few years of my early career, just kind of getting to know the various interest groups, and whether it's through AHPM or AEM, and it's a really wonderful group of us, and we're all doing such similar work, and it's been a great opportunity just to collaborate and hear how other institutions are thinking about this, so we can all learn from each other as we're advancing it. So thanks for the opportunity to get together, Maggie.
Yeah, I want to thank you, the panelists, so much. I really appreciate you sharing your time and your expertise. And I also want to thank everybody who came onto this webinar and who registered for it and showed interest in this. If anybody is interested in joining the palliative care SIG, we have Zoom meetings usually on the 4th Thursday of the month. We'd love to see you there. And I'm really excited about the future of both emergency medicine and palliative care, how we can work together in the ED and otherwise going forward. So thank you all so much. All right.
Thank you very much.